Venezolana de Cardiología. Nos complace mucho pues seguir en nuestras actividades de educación continua, específicamente en nuestra actividad conjunta con la Sociedad Igor Palacio, ya en nuestro tercer año, siempre con invitados de primera y con unos panelistas de primera también, que son nuestra sección de cardiología intervencionista. Y para esto, entonces voy a llamar al doctor Bartolo, que realmente es el que pues no sé, ha cargado con esta actividad para que no falte nunca. No es fácil lograr que invitados internacionales estén siempre dispuestos para ayudarnos, así que espero que todos nosotros aprovechemos mucho de esta actividad y luego vamos a tener una nutrida conversación. Bartolo, buenas noches.
Bueno, buenas noches a todos. Me contenta mucho saber que contamos a esta hora de la noche con la presencia de muchos miembros de nuestra Sociedad Venezolana de Cardiología y es un orgullo en particular saber bueno, esta es una de las actividades que más ha colaborado con la sección de cardiología intervencionista de la sociedad que sigue activa con un buen número de actividades o de webinar online. El día de hoy vamos a tener una charla, la primera charla que tenemos angloparlante con el doctor Jonathan Passeri. Es un médico muy reconocido en Estados Unidos por su labor, no solamente en las imágenes cardíacas, sino en lo que es el desarrollo del programa de Heart Team en el Mass General en Boston. Un equipo que ha sido particularmente de avanzada en el intervencionismo estructural para los Estados Unidos y que por eso es un gusto tenerlo hoy con nosotros al doctor Jonathan Passeri. Bueno, sin más que agregar para mantenernos en tiempo, vamos a seguir con la charla.
Explica el tema, Barto, ¿de qué va a hablar?
El tema va a ser de mejoría de la tensión en la estenosis aórtica.
Gracias.
Good evening. My name is Jonathan Passeri, and I'm the Director of Clinical Operations for the Echocardiography Laboratory at Massachusetts General Hospital. I'm honored to have the opportunity to speak to you this evening. I'll be speaking about improving care in aortic stenosis. Globally, rheumatic heart disease remains the most common etiology of valvular heart disease. With the contemporary antibiotic era, however, there has been a shift away from rheumatic heart disease and towards more degenerative diseases in the United States and industrialized nations. These diseases include mitral regurgitation and aortic stenosis more commonly than mitral stenosis, and they tend to occur at a later age than rheumatic disease. So we see a rather sharp increase in the prevalence of all valvular heart disease, and in particular aortic stenosis and mitral regurgitation, as people age in the United States. We know from the era before there were effective treatments for aortic stenosis that aortic stenosis carries a significantly bad history. In panel A, we see the classic natural history curve of aortic stenosis described by Dr. Braunwald and others, in which there is a long latent period. And when the aortic stenosis reaches the point of being severe and symptoms develop, the survival takes a sharp decline. Now, you'll notice that in that era, the age at which this tended to happen was younger, in the early 60s. Many more of these patients had rheumatic mitral valve disease or bicuspid valves than in the contemporary era. In panel B, we see essentially the same curve, but shifted in age range, where it is more degenerative calcific aortic stenosis that we are seeing now. It tends to occur later in life, and the latent period goes on longer. But nonetheless, when symptoms develop, that natural history curve takes the same shape with a sharp decline in survival if left uncorrected. In the right-hand panel, we see that aortic valve replacement, and in this case with surgical aortic valve replacement, is an effective treatment for mitigating that terrible prognosis from aortic stenosis. And this has been known a long time. Similarly, we saw that transcatheter aortic valve replacement conferred a very significant survival benefit to patients as compared to medical therapy with symptomatic severe aortic stenosis. And therefore, aortic stenosis is becoming a more common disease that is occurring later in life. It has a poor natural history and a very effective treatment with aortic valve replacement, either by surgery or transcatheter valve. And this information has informed our current guidelines here, which are similar to the European guidelines. Effectively, patients with severe aortic stenosis and symptoms or a decline in ejection fraction have a class 1 indication to undergo aortic valve replacement. Also, those with severe aortic stenosis who are undergoing heart surgery for another reason have a class 1 indication to undergo aortic valve replacement. Despite all of the data on aortic valve replacement, both surgical and transcatheter, and despite knowing that this disease has a poor natural history, there is a significant amount of people who remain undertreated. These data show patients who have aortic stenosis and have either a definitive or potential indication for aortic valve replacement, and how many of them are left untreated. In the orange panel, we see those with classic high gradient severe aortic stenosis who meet a class 1 indication for treatment. Essentially, they have symptoms or a low ejection fraction. And what we see is a significant percentage of those patients do not undergo aortic valve replacement. About 30% or so remain untreated. Now, many of them may have legitimate reasons for not being treated. Maybe they have concomitant medical conditions that are going to affect their survival, metastatic cancer, things like that. But still, there is a significant gap in those who meet an indication and those who are treated. It's even more so in patients who have a potential indication. And these are patients who do not have a class 1 indication, but a class 2 indication. They tend to be patients with low gradient low gradient aortic stenosis, with either low or normal ejection fraction. These are a group in which the decision-making is decidedly more complicated. But about 2/3 of those patients are not undergoing aortic valve replacement. Now, some of them may be appropriate, but it is unlikely that 2/3 of that population would not benefit from aortic valve replacement. So there definitely is a care gap in the treatment of aortic stenosis, despite all of the data that we have of its benefit. This care gap is not even across all income, racial, and socioeconomic groups. And this has been shown in multiple lines of evidence. So in the table, this is looking at age-adjusted rates of, in this case, transcatheter aortic valve replacement for patients with aortic stenosis. And it shows that patients with the highest income are statistically significantly more likely to undergo aortic valve replacement than those with the lowest income. Those who have better insurance are more likely to undergo aortic valve replacement than those with less good insurance. And when we look at the community index score, which is a socioeconomic measure, those that are the least socioeconomically distressed, those are the most affluent communities, are more likely to undergo aortic valve replacement as compared to those that are the least socioeconomically affluent. When we look across racial and ethnic groups, we see a similar trend. Now, using Caucasians in the United States as the control, we see that Asians, Hispanic, and Black patients are all significantly less likely to undergo aortic valve replacement of any sort, either surgical aortic valve replacement or transcatheter aortic valve replacement, as compared to Caucasian controls. Recently, a publication in Structural Heart used a automated rules-based algorithm to screen their echocardiography database to try to identify patients with varying degrees of aortic stenosis. It was quite an effective tool. It was 100% sensitive and over 95% specific for the detection of severe aortic stenosis. And all of these patients had been untreated. this rules-based algorithm demonstrated that about 11% in this particular echo database, which was in Los Angeles at Cedars-Sinai, so a particularly affluent community and affluent hospital, about 11% had untreated severe aortic stenosis. Furthermore, when they broke this down according to age, race, ethnicity, insurance, etc., there were some interesting findings. Now, you'll see two columns, and that is because not all patients had data to support a social determinants of health score. This is basically a score that looks at a variety of social and economic measures to assess patients' social determinants of health. So in the entire cohort, we see that there is a significant disparity in the treatment of aortic stenosis according to age. There is a trend towards some disparity with race and ethnicity that does not quite meet statistical significance. There is a great disparity based on insurance. However, in the subgroup of patients for whom there were data to assess a social determinants of health score and include that in a multivariate analysis, we see in this right-hand column that we unmask the disparities of race and ethnicity. So when we were able to account for the social determinants of health and put that into the multivariate analysis, we see that Black and Hispanic patients are significantly less likely to undergo aortic valve replacement. So the way to interpret this is there's some overlap between race, ethnicity, and socioeconomic status and social determinants of health. And when you have all of those data and can factor them into a multivariate analysis, you see what remains significant is race and ethnicity, not the social determinants of health. And so we know that symptomatic severe aortic stenosis is a serious disease that is associated with high morbidity and mortality when left untreated. We know that aortic valve replacement, whether it be surgical or transcatheter, is an effective treatment that prolongs life across all spectrums of aortic stenosis subtypes. And we know through multiple lines of evidence that aortic stenosis remains undertreated even in the contemporary era. And this is especially true amongst women, the elderly, and racial and ethnic minority groups. Timely treatment of severe aortic stenosis is a growing imperative. In fact, the American College of Cardiology and American Heart Association have set out a variety of clinical performance and quality measures in adults with valvular heart disease. And aortic stenosis is a clear target for performance and quality measures. The AHA target for aortic stenosis was an initiative that was launched with the intent to improve the care and outcome for patients with severe aortic stenosis upstream of aortic valve replacement. The performance measures are ready for reporting and pay for performance to include the proportion of patients with symptomatic severe aortic stenosis who undergo AVR within 90 days of diagnosis. So in addition to being the right thing to do for patients, there is now real incentives from the societies to meet quality targets to treat patients with aortic stenosis in a very timely fashion. So how can we improve the care of our patients and how can we help to meet these targets? Well, that leads into a trial that was conducted at my institution. I was fortunate enough to be a part of. It was spearheaded by colleagues of mine, Dr. Varsha Tangatori and Dr. Samuel Maria. It is called the Detect Aortic Stenosis Trial. The objective of this trial was to evaluate the efficacy of an electronic provider notification system in improving rates of aortic valve replacement for severe aortic stenosis within 1 year of having a diagnostic transthoracic echocardiogram. So this was a randomized trial in patients who underwent echocardiography with a reported valve area of less than 1 square centimeter were eligible. There was a 1-to-1 randomization of the providers, not the patients, the providers, to either receive electronic provider notification or to usual care. And the primary endpoints were the proportion of patients receiving an aortic valve replacement within 1 year of the index echocardiogram. So all providers, regardless of specialty, were eligible if their patient was enrolled. For the patient inclusion criteria, these were adults over the age of 18. They had to have an echocardiogram that showed an aortic valve area of less than 1 square centimeter, and it had to be within our healthcare network. And the longitudinal provider or the ordering provider of the echo had to be affiliated with our institution. And patients with prior aortic valve replacement were excluded. The provider attribution was done in a hierarchical format. So if the patient was already randomized to an arm, they retained that arm. If they were not, and they were seen by a member of our valve team, the valve team member was randomized. If they had not been seen by a member of our valve team, but had been seen by a general cardiologist, that cardiologist was randomized. If they had not been seen by a cardiologist, but by a primary care provider, that person was randomized. And if there was no cardiologist or primary care provider involved, it was the ordering provider of any specialty. And if there was no provider within the network, the patient was not enrolled. Providers who were randomized in the trial received one of 4 notification letters sent in the electronic health record. They related to whether it was high gradient or low gradient aortic stenosis and normal or low ejection fraction. So for patients who had an echo showing high gradient aortic stenosis with normal ejection fraction, the provider received a notification that informed them of the current AHA guidelines for the management of patients with that particular condition. Similarly, patients with low gradient aortic stenosis and low ejection fraction, they received a notification letter that provided information regarding the guideline-directed management of patients with that condition. And it also offered a easy pathway of referral to the multidisciplinary heart valve team. The endpoints were the proportion of patients receiving an aortic valve replacement within 1 year of the index transthoracic echocardiogram. Secondary endpoints were all-cause mortality, heart failure hospitalization, follow-up echocardiography, the appropriate coding for aortic stenosis, and just referral to a specialist. So these were all of the patients that were screened and the providers that were enrolled. It was 144 different providers for almost 500 patients in the electronic provider notification arm, and about 141 providers for about 440 patients in the usual care arm. The patient echocardiography characteristics were similar, and there was about just a little bit less than half were women. The average age was about 77. The comorbidities were similar, and the mean gradients, ejection fractions, etc., were all similar between the two groups. Now, for aortic valve replacement within 1 year, the rate in the usual care arm was 37.6%, and for those in the electronic provider notification arm was 47.8%, and this was a statistically significant difference. It was also statistically significant at 90 days. Now, restricting to symptomatic patients, in the usual care arm, about 47% of patients were ultimately underwent aortic valve replacement. In the electronic provider notification arm, 60%. And this was, of course, a highly significant difference. When stratified by sex, women versus men had a statistically significant utilization of aortic valve replacement in the usual care. So men were more likely to undergo aortic valve replacement than women in usual care. However, with electronic provider notification, the rate of aortic valve replacement was similar in women as it was to men in usual care. And for men with electronic provider notification, it was about the same in men as it was in usual care and similar to women with electronic provider notification. So in other words, what we see is in usual care, men had about the same rate of aortic valve replacement, whether there was electronic provider notification or not. However, for women, under usual care, there was a much lower rate of aortic valve replacement, but electronic provider notification mitigated that difference. And using electronic provider notification, the rate of aortic valve replacement for women was similar as it was to men in both groups. So it really mitigated this gender disparity. When we look across subgroups, patients who were older, women, tended to benefit from electronic provider notification. Now, these are two of the groups that we identified as having disparities, right? The elderly and women were two of the groups that we found to have an underutilization of aortic valve replacement. So this was an effective tool in helping to mitigate that underutilization and overcome that disparity. In terms of survival, there was no difference in survival in all patients who were randomized to usual care or having providers receive the notification. In symptomatic patients, however, there was an improvement in survival that was statistically significant, although it was modest. The difference was only about 23 days on average. But this is a relatively small group of people, and in a larger cohort, we might see a bigger difference. But it does show that it did get symptomatic patients treated more effectively with the use of the electronic provider notification. So what are the conclusions of this trial? Well, electronic provider notification did result in a higher rate of aortic valve replacement at 1 year and at 90 days. It was associated with a slightly longer survival time. And I think it strongly demonstrated a reduction in the sex-based disparities in aortic valve replacement. And it's a relatively simple and scalable tool to just raise awareness of potential severe aortic stenosis prognosis and improve guideline-directed assessment and management. Now, there are a number of limitations. These results may not be generalizable to all healthcare systems. Provider awareness of the study may have influenced referral patterns and treatment decisions. Some of the racial and ethnic homogeneity in our sample limits the evaluation of disparities there, and it may impact the generalizability to a more diverse population. And the inclusion of asymptomatic and pseudo-severe aortic stenosis by identifying patients only by aortic valve may have biased the results. So there are definitely limitations. Now, I'd like to shift to a conversation about the timing of aortic valve replacement in severe aortic stenosis. And this is somewhat timely because about a year ago, we saw the results of a randomized trial called Early TAVR. And these are a pretty well-evaluated group of patients. They had high gradient severe aortic stenosis that was confirmed. They were confirmed to be asymptomatic not only by clinical assessment, but by exercise testing to demonstrate a normal hemodynamic response to exercise. And they were randomized to either undergoing TAVR or undergoing a usual care of watchful waiting until class 1 indication of aortic valve replacement was met, essentially waiting until they develop symptoms. Now, there's a lot of interesting findings in this trial. I think the first really interesting finding is over in this panel B, where it says conversion to aortic valve replacement. And so these are the group of surveillance patients randomized to surveillance and the rate at which they developed symptoms and therefore underwent aortic valve replacement. And what you'll notice is that at the end of a year, nearly half had come to develop symptoms and require aortic valve replacement. At the end of 2 years, it was 71%. At the end of 3 years, 86%. And of course, you go further out and you're just approximating all patients. So I think the first interesting finding is once a patient reaches the point at which they have severe high gradient aortic stenosis, they are not far away from needing an aortic valve replacement. About half will come to need it within a year. Nearly more than 2/3 will come to need it within 2 years. So we're not talking about, years and decades. We're talking about months to a year or so for most patients. So I think that's an important thing for us to bear in mind. The second interesting finding is there was no difference in death from any cause between these groups. And I think that's important because there is a concern about sudden cardiac death and aortic stenosis that is based on very old data, which I could be critical of. But I think in patients who are truly asymptomatic, it does not look like they are at risk for dying at a rate higher than those who undergo TAVR by engaging in watchful waiting with close surveillance. There was, however, a difference in the composite endpoint of death, stroke, or unplanned hospitalization for cardiovascular causes. And that difference was driven entirely by a statistically significant difference in unplanned hospitalizations for cardiovascular causes. Now, some of those patients may have developed some acute heart failure and been hospitalized. But within the definition of unplanned hospitalization for this trial, any patient that didn't make it to their next scheduled outpatient appointment in the surveillance arm and called to report routine symptoms and underwent treatment before that next appointment was considered to have had an unplanned hospitalization. So in other words, when I see a patient with severe aortic stenosis and no symptoms, and I schedule a follow-up in 6 months, I tell them, please call me if you develop chest pain, shortness of breath, or any other symptoms before our next visit. You don't have to wait. You can let me know beforehand. And if they call beforehand and report those symptoms, then we move ahead with aortic valve replacement. Well, in this trial, those patients counted as having an unplanned hospitalization, even though it was just really an elective treatment of their aortic stenosis for new onset symptoms. Just some context for this. Nonetheless, it was a difference. And again, it does show us that patients with severe aortic stenosis are going to go on to develop symptoms in a relatively rapid way. Now, this was another publication recently that looked at patients who underwent aortic valve replacement, severe aortic stenosis, and grouped them into 3 groups, which they referred to as having stable valve syndrome, progressive valve syndrome, or acute valve syndrome. What do those things mean? Well, per the definitions of these investigators, stable valve syndrome meant they were asymptomatic. Progressive valve syndrome are the usual exertional symptoms that we think of in patients with aortic stenosis. So they have shortness of breath on exertion, they may have chest pain on exertion, something like that. The symptoms are not severe. They tended to be class 1 or 2, New York Heart Association, and they had normal ejection fraction. The acute valve syndrome were patients who had New York Heart Association functional class 3 or 4 symptoms, acute heart failure hospitalizations, or low ejection fraction. And they looked at the cost and resource utilization as well as clinical outcomes across these 3 syndromes. Now, in the graphs and the figures where we look at 1-year clinical outcomes, it's, I think, unsurprising that the group they considered to be acute valve syndromes, so these are people who have low ejection fraction, advanced heart failure symptoms, that they had a higher mortality rate than the other 2 groups. They had a higher heart failure hospitalization rate than the other 2 groups. So waiting till the symptoms are very advanced seemed to be of less benefit than getting to these symptoms sooner. Now, as for the difference between the stable valve syndrome, so the asymptomatic group, and the progressive symptoms, so the typical symptoms that we consider to be our class 1 indications, In isolation, there was no difference in the rate of mortality or heart failure hospitalization. When you combine those two, there was a slightly significant difference between their outcomes. I would caveat that by pointing out that only 1% of the entire cohort were asymptomatic, so it's hard to compare. I think it does tell us, though, that treating patients a bit earlier when they have stable symptoms is going to be of more benefit and less cost than waiting until patients have severe advanced symptoms or a low ejection fraction. Now, that's not to say that those patients at that extreme end don't benefit from aortic valve replacement. They do. And in fact, again, to point to the partner trial, in the inoperable arm where patients were randomized to either medical therapy or TAVR, these patients all by definition were very symptomatic. If you see at baseline, almost all of them had class 3 or 4 symptoms. So these would have been, per that prior study, acute valve syndrome patients. And they had a very statistically significant improvement as compared to medical therapy and death from any cause, death from cardiovascular causes, death or stroke, across the board. So those patients still benefit. It's clearly still a very beneficial therapy. So we haven't passed the window in which the treatment is still useful into futility. It just may be that they benefit more if we had gotten them to them a bit sooner. So the way I think about this is, rather than a single point in time, there's a window of opportunity in which people will benefit from aortic valve replacement. And we have to try to find the optimal time within that window for that patient. Now, care of patients who undergo aortic valve replacement for aortic stenosis doesn't stop with replacement.
Driveway camera. And person seeing zone 1. Driveway camera.
We know that how we manage them after valve replacement is important. So here is data that shows that the use of ACE inhibitors or angiotensin receptor antagonists after TAVR, in this case, basically was associated with an improvement in all-cause mortality, cardiovascular mortality, and reduction in the rate of new onset atrial fibrillation. So just replacing the valve isn't enough. We have to make sure they're on the right medications. Even more impressively is the use of SGLT2 inhibitors. And so these data looked at patients who underwent transcatheter aortic valve replacement for severe aortic stenosis and were randomized to receiving an SGLT2 inhibitor versus standard care. And there was a statistically significant difference in the reduction in the rate of death from any cause or worsening heart failure in those treated with an SGLT2 inhibitor. And so medical therapy is still important after we replace the valve. We can't just celebrate that the valve is replaced and that our job is done and the patient is cured. They still have a chronic disease that requires management. We also have to be mindful of some of the complications that can occur after aortic. Now, we should be mindful of some of the complications that can occur after valve replacement. So one potential complication that we have an increasing recognition of is leaflet thrombosis of the prosthetic valve. This is very effectively identified by CT scan. It is referred to as hypoattenuating leaflet thickening, which is really a subclinical thrombosis of the leaflets. And we know that this is associated with worse outcomes in patients and more accelerated valve degeneration. It can be usually treated with therapeutic anticoagulation, whether that is with a DOAC or warfarin, I think is somewhat controversial. But it is something to be on the lookout. If you are following patients and you notice that the gradients across the prosthetic valve are increasing following replacement, we should move to a CT scan to be looking for this hypoattenuating leaflet thickening, this thrombosis, so that we can treat it. Another thing that we should be mindful of after valve replacement is the infective endocarditis. So having a prosthetic valve as compared to a normal valve is associated with an increased risk of endocarditis. And of course, when one has it, it is associated with very poor outcomes. And so we have to be mindful of mitigating the risk of endocarditis. We do recommend the use of prophylactic antibiotics for dental procedures and certain other procedures. We have to have a very low threshold for looking for endocarditis in patients who have a prosthetic valve and have fevers or infectious symptoms. So in closing, I would like for everybody to think of aortic stenosis not as a disease we follow and then hit a specific point, replace the valve, and then we're done, but rather a whole continuum of care for these patients. There is a progressive phase in which we should be actively trying to screen patients for aortic stenosis. Frankly, for aortic valve calcification, even before it is causing hemodynamic stenosis of the valve. We should ensure that they have appropriate surveillance and clinical visits. We should do everything to modify their risk factors. I didn't talk about it specifically, but there are several drugs in development that are targeted at slowing the calcification process, slowing the progression of aortic stenosis. And perhaps these will prove to be positive. And if they are, that will give us some tools in the progressive phase to delay the progression of aortic stenosis and delay the time in which they might come to need aortic valve replacement. We should ensure that we're using appropriate use of adjunctive testing. We should be using CT scans for calcium scores when clinically appropriate. If we're unsure of a patient's symptomatic status, we should be using exercise testing, invasive testing when necessary, et cetera. And this should be the phase in which patients are referred to a multidisciplinary valve team or a valve specialist to follow them, not waiting until they meet an indication for intervention. Now, speaking of an indication for intervention, we should rethink of this rather than a hard point in time that is an indication, but rather a window of time in which intervention should be considered. This really should begin with when the valve is severely diseased, before the onset of symptoms. We have data from that early TAVR trial that is a reasonable time to start thinking about intervention. And even patients with advanced symptoms, even patients with low ejection fraction still benefit. And it is really only when they have a very poor prognosis from other things that they are not going to derive some clinical benefit from aortic valve replacement and it has reached the point of futility. So the window starts with the asymptomatic severe patient. It kind of ends with the point at which it has now become futile. Now, where within that window a patient should be treated has to be individualized to that patient. The choice of valve replacement procedure, surgical or transcatheter, and the prosthetic valve selection should also be individualized. And then we're not done when the valve is replaced. We have to think about that next phase as the post-valve replacement continuity of care. We have to ensure that they're on appropriate medical therapy, which is going to reduce adverse cardiac events and mortality. Think of this still as a patient who has a chronic heart disease. Remember, they have a prosthetic valve, and prosthetic valves are associated with prosthetic valve-related complications. We have to be mindful of those, like leaflet thrombosis, like infective endocarditis. We have to identify early signs of any of this prosthetic valve dysfunction so that we can effectively treat it. So in conclusion, underdiagnosis and undertreatment of severe aortic stenosis is common. Racial, gender, and socioeconomic disparities in the treatment of aortic stenosis are clearly prevalent and need to be addressed. The trial we did with electronic provider notification is one simple tool that may help to improve these things, but it is not the whole solution. I think it is going to take many different avenues and approaches to try to address these. I think we should reconsider what we call the optimal timing of aortic valve replacement into a window of opportunity, a window of time. And then we have to make sure that we're optimizing care throughout the entire continuum of this chronic disease, from the progressive stage through the intervention and after the valve is replaced. Thank you so much for your time and attention.
Bueno, muchísimas gracias por la oportunidad al doctor Jonathan Passeri. De verdad que es un orgullo para nosotros en la Sociedad Venezolana de Cardiología contar el día de hoy con un grupo tan nutrido de participantes. El día de hoy tenemos al doctor Carlos Calderas y al doctor José Miguel Torres, que han estado coordinando esta actividad durante los últimos 2 años y hoy ya vamos para el tercer año. Y es un orgullo pues que nos acompañe porque siempre tenemos mucha experiencia y mucha información que obtener de las discusiones. También nos contenta de parte del grupo quirúrgico está el doctor Chadi Nasser participando en la actividad con nosotros hoy para poner la parte de los cirujanos. Y de la Sociedad Igor Palacios, pues contamos con el doctor Jonathan Passeri, quien muy amablemente se conectó a esta hora para que podamos compartir preguntas y respuestas. El doctor Igor Palacios, pues, idea y fundador de la sociedad. Y estamos con la doctora Iris Flores, que también se pudo conectar de Ascardio. Y el doctor Miguel Caldera, que forma parte de la sociedad Igor Palacios y que bastantes oportunidades nos ha acompañado en los eventos académicos de la Sociedad Venezolana de Cardiología. Él es un cardiólogo en la ciudad de Austin, Texas. Bueno, además de eso nos acompaña pues de la directiva de la Sociedad Venezolana de Cardiología, está el doctor Lempira Guevara, la doctora Josefina Feijó y el doctor Vicente Finisola. Bueno, ya presentándoles este Dream Team, yo creo que es momento para que comiencen las preguntas y respuestas. El doctor Jonathan está, digamos, muy dado a contestarlas y podemos hacer de traducción, doctor José Miguel. Carlos.
Lo que Bueno, en principio, dar las gracias al doctor por su magnífica presentación. It was a wonderful presentation with a lot of pretty actual data, including the trial that you, in some way, direct about the following of the patient with a electronic notification that I think is quite relevant data because in some way coincide or overlap the result of the early TAVR intervention. I don't know if you consider that the early TAVR intervention at the result of your trial can accelerate a little bit in your department, in the real life, the indication of the workflow through the resolution of any affect severe or the stenosis beyond the symptoms. Le pregunté al doctor acerca de los resultados de su trial que fueron muy interesantes porque de alguna manera coinciden con algunos resultados del early TAVR y la intervención temprana en cualquier estenosis aórtica severa en la idea de contener las complicaciones. In order to the early intervention in some way content or stop the rate of decrease the rate of complications in this type of patient. I would like to hear your comments about this point. Very interested about your commentary.
Well, thank you. First, I just want to thank you all for inviting me to participate in this wonderful meeting. I'm very honored to join you all tonight. And
you are a very great group of attendings hearing your intervention, doctor. You have more than 100 people at that age, at that hour. How many patients? How many attendings?
I'm honored to have so many friends joining
125 Venezuelans.
I'm very honored to have so many friends to listen to me and join me for this discussion. Thank you for the question. It is I think, a very important and relevant issue that you are asking about. I do think that the results of the early TAVR trial build upon prior work that will lead us towards being more aggressive in the timeline of intervention. I think our trial was one way in which electronic provider notification can accelerate the evaluation of patients. It is not the solution to all of the problems. But I think these are stepwise and iterative things that will help us to accelerate the evaluation of patients and treatment. But there are still great issues with getting patients with severe aortic stenosis seen, evaluated, and treated in a timely fashion. And there remains disparity in the patients. So it is unequal depending on their socioeconomic status, race, ethnicity, as to who is treated more aggressively and in a timely fashion. So we are far from solving this problem. This builds on data that tells us that earlier intervention or intervening sooner in that window of opportunity is going to lead to better outcomes. This trying to leverage electronic tools is going to be helpful, but we have a lot of work to do as a community to educate patients, to educate referring physicians about timely referral and treatment. So there's a long way to go. In the United States, I think the moves of the societies to create some quality metrics which will link to reimbursement will be a very good motivator for the medical community to do this.
Exactly, always.
There's still a lot of work to do.
Exactly, absolutely.
Si quieres lo traduzco brevemente. El doctor John habla mucho y es gran parte del tema de la charla. No es solamente el aspecto del momento del diagnóstico al momento al momento de la intervención per se, que es el retraso financiero al cual estamos acostumbrados. Una de las cosas que le estaba mencionando es la disparidad entre grupos en la posibilidad de recibir el diagnóstico y la propuesta. O sea, no proponerle al paciente que tiene la indicación de intervenirse de manera precoz, y eso es algo fundamental, ¿no?
Sí, por supuesto, especificó que la notificación electrónica en anticipación pudiera mejorar los tiempos, pero no es, por supuesto, la única solución, pero pudiera ser que cuando tienes el reporte de una estenosis aórtica severa, tratar de que el que provee la curación reciba la información, acelera un poco los tiempos. Los Estados Unidos están tratando, por supuesto, de que esto se convierta en que además el que interviene reciba el adecuado pago por la intervención. No sé, Vicente, y
sí,
que te está solicitando la palabra para hacer una pregunta.
Ángel.
Carlito.
Ángel, me voy a adelantar porque hay un STEMI por ahí y posiblemente tenga que retirarme.
Adelante.
Ok, dale.
Disculpa, Ángel. Dr. Passeri, great presentation, and we all enjoyed your speech. I just want to make a question. Maybe it's not only medical. You share with us some information about the disparity in the accessibility, maybe depending on ethnicity, depending on regions, depending on gender. So we would think that the accessibility in the United States shouldn't be more equal. So what do you think is the main factors that is affecting such difference between social groups?
Thank you. This is an excellent question. Unfortunately, in the United States, in most conditions we look at, we see very similar trends of disparity. And it is frequently been thought that the socioeconomic factors and the social determinants of health were the primary reasons for the disparity. So patients who are in more affluent communities with better health insurance, more accessibility to major centers in cities. It was always thought that this was probably the major driver of why people would have better access to care, and that certain of the ethnic disparities would track those. What's interesting about the data that we have seen in this, and I had presented one of the studies, is that when you account for social determinants of health, at least in one of these trials, we still saw disparity, actually exacerbated disparity by ethnicity. And so there is something else to this beyond, certainly beyond the social determinants of health that are measured and captured in the data. Now, whether this is regional, so where in certain regions in the United States there are greater populations of different ethnic groups, and they may be in regions where healthcare resources are more limited. So it may seem, the United States is not homogenous. We are 50 states, and healthcare in each state varies quite significantly. And so some states have much less resources for healthcare. The hospitals and medical centers are much further apart. And in many of those states that have less resources for healthcare, we see greater populations of certain ethnic minorities. So in the South and some of the less affluent, poorer states in the South, we see greater populations of Black, African American people. In certain Southwestern states, we see more Latino. And so it could be a regional issue that is part of that, but we don't have enough data to really know if that accounts for things beyond the socioeconomic gap. So a lot more research needs to be done to understand why this is there. But I think the old thinking that this was purely a reflection of affluence and socioeconomic is not correct, right? There's more to it. Part may be region, but part, I think we don't have enough data to understand it.
Claro. El doctor Ángel Caldera, que creo que es uno de sus alumnos, doctor Jonathan,
Sí.
está identificado, realmente hay varias personas identificadas como el doctor Bartolomé Finisola, que colonizó pues la pantalla, pero en realidad es Ángel Caldera el que va a hablar. I think
Sí.
one of your trainees is going to ask us
Bueno.
a question for you, Dr. Passeri.
Sí, bueno, buenas noches. Antes que nada, le quiero agradecer a la sociedad la invitación. De verdad que es un honor estar aquí y en especial que invitaran a Jonathan porque él es como nuestro compás moral cuando se trata de intervenciones, ya que más bien nos contiene para que no estemos interviniendo cuando es necesario. So, Jonathan, I was thanking the society for the opportunity for my participation, and also I was telling them that it's good to hear you in favor of early intervention because you have been a moral compass in when to intervene. So, coming from you, it has even more value. I wanted to talk to you about the Detect AS, and then I have a comment. Did we have enough patients to make a differentiation between the kind of aortic valve replacement, whether it was surgical or if it was TAVR, just to see if the differences that we saw favoring the elderly could have been that they predominantly received TAVR, which, it may have a lesser morbid mortality in the short term. Could it be that the kind of revascularization had something to do with the outcomes that we saw there? That's the question. And the quick comment is, when we talk about disparities and ethnicity, I think there are cultural biases. Fear of seeking medical attention is a reality in the Hispanic community, particularly these days is a very real thing. People with chest pain is staying at home out of the fear of not going to the hospitals. But there is also the fact that, who is taking care of you? Does he look like me? Is he like me? Does he really get me? So I think that everything that can be done in terms of increasing diversity in the provider pool will also help to diminish these cultural biases. So. But the question is about AVR, TAVR, or surgical AVR in Detect AS.
Yes, well, Angela, it's wonderful to talk to you.
Yes.
And thank you for the question. So the short answer is most of the patients in Detect AS that were treated were TAVR rather than surgery, particularly in the group in which we saw the greatest difference, which tended to be the women. And many of that was driven by low gradient AS, where we picked up a lot of patients and they were sort of undertreated, I think, in the conventional arm. So it's an excellent question whether we would have seen that if that same particular group of people, elderly women, smaller body size, lower gradient, were treated with surgery, we may not have seen the difference. So part of this may be driven by the type of intervention. Honestly, I think there probably was not enough numbers to run that kind of statistical analysis, but it is a very good point. And I don't have data on any coronary revascularization as well. And I think your comments are absolutely correct. And unfortunately, in these current times, not only do I think the fear of seeking medical attention is exacerbated, but the uh, bringing in medical professionals from around the world, which we used to do in the United States, and increase the number of providers, which we had a deficiency of, and create a very diverse group of healthcare providers and physicians, is unfortunately also suffering these days, and I think is another real problem.
Thank you, Jonathan.
No sé si Ángel,
Ángel,
Sí.
¿quieres resumir un poquito la respuesta? O sea,
Sí,
¿quieres
sí,
traducir un poco la respuesta?
Si me permite, sí, cómo no. El estudio del Detect AS demostró que el reemplazo valvular beneficiaba particularmente a las personas mayores y a las mujeres. Entonces yo pregunté si había una diferencia, si el reemplazo se hacía de forma transcatéter o quirúrgico, porque hay beneficio en mortalidad a corto plazo cuando es transcatéter. Y ciertamente la mayoría de las personas mayores de 80 años y las mujeres fueron transcatéter. Y es posible que eso haya contribuido a que se viera el beneficio mayor. Yo también le pregunté si podía ser que eran diferencias culturales en las minorías, lo que hacía que hubiera menos acceso a terapias, no solamente por la parte socioeconómica, como le enfatizó, que no era tan relevante, sino que quizás también había un sesgo cultural, como sucede en este momento, que hay muchas personas en sus casas que no buscan atención médica con el miedo de que en el hospital los reporten
Migratorio,
y
total.
terminen en un asunto migratorio. Y entonces él
Total.
dice que eso es posible, que probablemente contribuye, pero que también hay un problema desde el punto de vista del pool de proveedores, porque las oportunidades que había en los Estados Unidos para entrenar gente en cualquier rincón del planeta están siendo limitadas con restricciones también en visas de entrenamiento, y que eso es una razón de preocupación. Pero esa fueron mis preguntas. Jonathan, it's really a pleasure. I cannot tell you how much I enjoy your talk. Thank you.
Thank you.
Gracias, Ángel. Great. Carlito.
Well, Dr. Passeri, thanks a lot for your wonderful presentation. And I just want to know your thoughts about there is another subgroup of patients in which we are exploring the opportunity to go for an early intervention, which is the moderate aortic stenosis in patients with low ejection fraction. So I would like to hear your thoughts about this population, and if you think in the future is going to have results like what we're seeing in this early TAVR procedure with a patient, the study with patients with no symptoms.
Thank you for the question, Carlos.
Carlos, después Carlito le preguntó acerca de estenosis aórtica moderada y la posibilidad de intervención temprana aún en estos pacientes, más o menos, ¿no, Carlos? ¿Estás de acuerdo? Total.
Mm-hmm.
So it's an excellent question. This was studied in a trial called TAVR Unload, where patients with moderate aortic stenosis and reduced ejection fraction were randomized to ongoing medical treatment or TAVR. And it was a negative trial. It showed no benefit, despite, I think, many efforts at looking at the statistics in a lot of ways to try to see if there was any potential benefit or any groups that may benefit, but it was quite a negative trial. Now, it was a slow enrolling trial. There were, I think, a number of criticisms of trial design. So, like many times where we have a hypothesis that seems to make sense and we have a trial that seems to be negative, I don't think it is the end of the story. I think there will be some lessons learned from that and taken forward. There is, of course, another ongoing trial of moderate aortic stenosis in general, which is going to incorporate groups with normal ejection fraction as well as reduced ejection fraction. And just like we've seen with, MITRA-FR and COAP, where we sometimes need 2 or 3 trials to see if there's a trend line or if one is an outlier. I think it remains to be seen whether this will be a group that will benefit. Right now, based on TAVR Unload, the answer seems to be no. I suspect it's a more nuanced answer than that. I think that there is going to be a subgroup of patients with lesser degrees of aortic stenosis that do benefit, but it's going to take some trials to kind of parse out who those patients are that benefit and who are not. So I suspect we'll be studying this for quite a number of years before we come to a firm answer. I also suspect that while those trials are being done, there's going to be a lot of moderate aortic stenosis that gets treated in the world with TAVR.
Yes.
And many labels has low flow, low gradient.
Yes,
Absolutely.
exactly.
And in moderate aortic stenosis, do you use the calcium score to accelerate a little bit the indication in your department?
Yes, so I think this is really an interesting question because, I think, and I wish the data were stronger, but I think we incorporate calcium score as yet another measure. So if you have echo parameters that all fall within moderate, but a calcium score that is quite significant, I think it becomes one of these questions: is it truly moderate? Is it severe? And I have seen, certainly that gets treated a lot. There are people who will take that and say, this patient's symptomatic, their calcium score is very high.
Particularly if the patient is symptomatic, eventually
if the patient is symptomatic,
yes. Exactly.
I think in the asymptomatic group, we probably would not, but I think it is another integrated data point there. Yes.
El doctor le respondió a Carlos, Carlos, traduce tú lo que te respondió acerca de la moderada.
Bueno, de manera resumida, él explicó que en vista del estudio, el TAVR Unload, que fue un estudio negativo, no estamos todavía en capacidad de tratar a estos pacientes de una manera responsable, o sea, los pacientes que tengan una estenosis aórtica moderada y fracción de eyección baja. Sin embargo, que claro, parece una oferta tan atractiva porque dices, wow, estos pacientes pareciera que se deberían beneficiar, que esto se va a seguir estudiando en varios estudios a lo largo de los próximos años, porque suena que es muy lógico que estos pacientes deberían beneficiarse. Pero todavía, pues, probablemente se identifiquen en el futuro unos subgrupos de pacientes que sean los que dentro de este grupo, pues, se beneficien, pero que hoy día todavía tenemos que esperar.
Yo le pregunté luego por el calcium score de la válvula para decidir en una estenosis aórtica moderada si eso aceleraba la indicación. Y nos dijo que lo usan como parte de los indicadores, no para tomar una respuesta definitiva, pero si el paciente está sintomático, tiene una estenosis aórtica moderada y tiene un alto calcium score de la válvula, probablemente acelera la indicación para beneficiar al paciente tempranamente.
Doctor, Chadi tiene un comentario y creo que tiene una emergencia también.
Perfecto. Chadi. Dale, Chadi. Creo que estás muteado.
Tienes el micro apagado.
Tienes el micro apagado.
Okay. Buenas noches. Buenas noches. Gracias por la invitación a la Sociedad Venezolana de Cardiología. Doctor Passeri, excellent conference. Thank you. Mi pregunta tiene que ver un poco con el estudio Early TAVI. ¿Usted cree que sea la punta del iceberg para cada vez hacer esta indicación más precoz en estos pacientes, tomando en consideración comparando TAVI versus cirugía, ¿ok? Que es mucho más fácil indicarle a un paciente asintomático que se haga un TAVI que se haga una cirugía, por supuesto por el el método invasivo que representa. ¿Qué opinión tiene al respecto de esto? No sé si Bartolomé me puede ayudar a traducir.
Tienes el micrófono apagado, Eduardo.
First of all, hi John. It's a pleasure. I did get to introduce you, but not in English. Sorry. What Dr. Chadi is asking, who is actually the only surgeon connected so far, is
It's a very brave specialist that is connected in this forum.
very very good surgeon. So he's a non-peer surgeon. So Chadi, what he's actually asking is that once you go to the early TAVR results, you're gonna have patients getting intervention earlier. And so it's very important to know which kind of intervention do you see in the scope, because obviously if you tell somebody whichever age they have that they are going to undergo open heart versus a TAVR, probably the trend is gonna go for the patient selecting TAVR. But actually the real data, how do you analyze this, and what would be your opinion regarding which kind of intervention?
So it's a great question. Obviously, there is not a direct surgical trial of randomizing people to surgery or medical management. So we must extrapolate, I think, from the low risk TAVR versus SAVR data and then the early TAVR, right? And to my mind, if we put these things together, valve replacement by any means is the thing that is of benefit to the patient, right? And whether it is during the asymptomatic phase being severe, and there is historic, not randomized, but there is some historic observational data in the surgical field of surgery for very severe aortic stenosis in the absence of symptoms. So I think it is not whether it's early or not that is going to matter as to which intervention, or which intervention is going to benefit a patient is not really related to whether we're in the asymptomatic phase of severe or not. It will be what is the better procedure for that patient based on their anatomy, their risk, et cetera. So that will still be true. So I think, again, my thinking of this, which continues to evolve as the data comes through, is for each patient, we look at intervention as a window of opportunity. And there's some window in there which is going to be the optimal time. I think right now, before the valve is severe, we don't have enough data to say that's it. When the valve is truly severe, high gradient aortic stenosis, that begins the time when it's reasonable to consider intervention. And we don't want them to get to advanced heart failure symptoms, LV dysfunction, et cetera. In that window, which intervention and exactly where in the window is dependent, I think, on their risk of intervention, their anatomy, and these other things. So our decision-making between TAVR and surgery is still based on the same factors I think we consider in the symptomatic population, which is what is going to be the best for that patient from a risk standpoint, which is going to be the best from an anatomic standpoint, and which is going to be the best, and this may be more relevant in the early TAVR, which is the best for the lifetime management of this patient. So what is our approach for their durability over time? And we are seeing this trend, right, where younger people are wanting TAVR, and I'm honestly not sure that's correct, right? Whether that's the best lifetime approach, and we'll see. But I think it's one more thing that pushes us earlier on. But I still think the decision between the procedures is the same calculus we think now, right? Which is risk, anatomy, and lifetime management.
Bueno, I was just gonna say one short comment. I think that this new data fits us like a fine leather glove. The reason being because we are a country where we have a lot of delays between diagnosis and treatment. So making an earlier diagnosis is a lot better for our patients because we make an early indication and then we have a little bit more time to treat the patient before they get into the symptomatic window of complications regarding prognosis and quality of life. Entonces el doctor mencionaba que no se trata de cuál será la mejor técnica, sino de que el tratamiento sea oportuno. Y esto, así como mucho de lo que se ha llevado a cabo con la sociedad y el tratamiento de la cardiopatía estructural, el diagnóstico y el tratamiento apropiado es lo que ha dado buenos resultados, no tanto el tema de cuál es la mejor intervención. Y él trae a colación un punto que no está mucho en las guías clínicas, pero que sí hemos escuchado varias veces, que es la anatomía del paciente y el manejo de por vida. No estando muy de acuerdo con plantear TAVI en personas cada vez más jóvenes, pero que hay que evaluar otros elementos aparte. Y eso es muy importante porque eso no está en las guías, pero muchas veces nosotros cuando vemos que un paciente tiene una anatomía que nos va a dejar con una fuga paravalvular severa o con gradientes muy altos o con alto riesgo de obstrucción de las coronarias, eso pareciera ser lo que nos dé la luz de mandar
La indicación.
a cirugía, porque no podemos ofrecerle un buen TAVI. Entonces, creo que ese elemento del manejo de por vida, obviamente defendiendo el tratamiento percutáneo, pero
Pero
consciente
por
de
supuesto.
la realidad es que si el paciente no tiene una buena anatomía, eso viene a formar gran parte de lo que estábamos hablando y creo que aprovecho, me disculpan de que eso responde al doctor Joel Juárez que nos había hecho una pregunta por el chat.
Excelente, Berto. Ángel.
Sí, tengo un par de comentarios. Cuando hablamos de la disparidad en el acceso al reemplazo valvular que se ve dentro de los Estados Unidos, no podía dejar de pensar yo en la situación en Venezuela y esperar a que el paciente esté con dificultad para respirar extrema y con síntomas avanzados para entonces poner a la familia a dar carreras a coordinar el reemplazo valvular no tiene sentido. Este es un mensaje un poco para las
Total.
personas que ven esta enfermedad y que lo refieran cuanto antes para que empecemos cuanto antes el workup, porque no es al otro día que le haces el reemplazo valvular. I was just commenting, Jonathan, about the disparities, and in a country like Venezuela, it's difficult to access. So what you have said today is very important because it gives time to the families to prepare to what is coming up. And, it gives time, as Bartolome was mentioning. And the other thing I wanted to say is that your point about the SGLT2, whenever I hear you, I learn something new. I wasn't aware about the randomization of patients after TAVR with SGLT2 inhibitors. Is it a mortality benefit that you
It's
show?
mostly heart failure hospitalizations are reduced.
Heart failure, but I'm not doing that routinely in my patients, and maybe I should. And this was regardless of the ejection fraction.
Correct.
Yeah, that's fascinating. También estaba
Actually, I think it
comentando.
was normal ejection fraction specifically in this trial.
Good. I'm going to look it up because, Philip Generox show the staging classification, and then only a minority of patients improve their staging after replacement, whether it's TAVR or surgical. But there is a subset that worsen, and those who worsen are those who don't have the blood pressure managed properly, and those who underwent aortic valve replacement surgically in a subgroup analysis that he did. So I think that I have been very aggressive controlling the blood pressure, and now I will try to push for the SGLT2. Yo estaba haciendo el comentario que cada vez que oigo al doctor Passeri, aprendo algo nuevo y sabíamos de antes que después del reemplazo valvular controlar la hipertensión arterial es importante porque el estadio de la enfermedad cardíaca progresa a pesar del reemplazo valvular si no controlas la presión arterial. Y él mostró la data de que los SGLT2 inhibitors, Jardians y su familia, tienen una ventaja en términos de readmisiones. Yo pensé que era mortalidad, readmisiones en pacientes con fracción de eyección normal según después de TAVR. Esos eran mis comentarios. Gracias. Thank you, Jonathan.
Something came to my mind, if I can make one more comment. This was to what Carlos and I were discussing earlier about moderate aortic stenosis. And before I forget, there's an increasing understanding about mixed valve disease, meaning a concomitant presence of aortic stenosis and aortic regurgitation. And so one group of patients that are likely to act more like severe aortic stenosis patients and have potentially the benefit of valve replacement are the moderate aortic stenosis patients who have concomitant moderate aortic regurgitation. And so this is an important thing for us to be bearing in mind. The combination of moderate stenosis and regurgitation, that mixed disease, we should think of them more like a severe lesion of either type. And if they certainly have symptoms, we should treat them aggressively as well and monitor them, as well. So that is one feature The data is a little mixed on it, but we're seeing a real signal with that particular group. So something to bear in mind.
Absolutely. Great comment. Very teaching point that is pretty good to take home. Carlos, ¿tú quieres traducir lo que él dijo acerca de la moderada con concomitante rehabilitación?
Sí, seguro. Pues él nos ha mencionado que hay dentro de estos pacientes con estenosis aórtica moderada, aquellos que aparte de tener estenosis aórtica moderada tienen insuficiencia aórtica importante, moderada, que pudiesen ser considerados y que sean sintomáticos. Podrían ser considerados como un paciente que tuviese una estenosis aórtica severa y que probablemente se beneficien de ser tratados, ¿no? Hoy tuvimos,
Increíble.
hoy
Ya con
tuvimos
eso
un caso
nos
de,
podemos ir acostar. Exacto.
sí, sí. Hoy tuvimos un caso así, estenosis aórtica que era, sí, en este paciente era severa, pero imagínate tú, tenía la diastólica en algo así como 30, con 200 de sistólica.
Wow.
Y sí, era un caso de eso con insuficiencia.
Ese se beneficia más todavía. Ese se
Sí,
benefició al tope de la intervención
exactamente.
temprana. Total.
Sí.
Doctor, you are a quite expert in images. How do you follow up the patient after the implant? Do you have any specific workflow in order to follow up and try to detect any abnormality in the left ventricular function, in the right ventricular function, in the valve? How do you follow up this kind of patient after implant?
Yes, thank you. It's a great question. So I would group this into the routine. So a patient with normal ejection fraction who has intervention, they have normal ejection fraction and they're doing well symptomatically. We follow them with echocardiography at about 1 month after procedure and then annually thereafter. We will do an echocardiogram if there's a change in symptomatic status. Now, in the group of patients where they have abnormal left ventricular function, or some other adverse remodeling, I will follow them more closely in the aftermath. So I will look at 1 month, 6 months, and 1 year, basically every 6 months to see if there's a change in ejection fraction. And this is to help guide any changes to medical therapy that we want to introduce over time. Sometimes these are people who we may consider additional interventions towards their heart failure management. So it is somewhat dependent on the clinical status and where they're heading in. But in the most routine patient, once you've gotten past the 1 month, it is annual surveillance echocardiography unless there is a change in symptoms. And I do that every year. Or if there is some finding on an echocardiogram that bears more change. So let's say we identify somebody who develops HALT, right? They've got HALT. We see an increase in gradients at the 1 year time point. We will do a CT scan to evaluate for HALT. We find HALT. We start on anticoagulation. I will then do echocardiography in 3-month intervals to assess for resolution, improvement in gradients, or worsening, because that will make a change potentially to the aggressiveness of anticoagulation. And if they really fail this, and I've unfortunately seen this, we sometimes have to re-intervene. There are some people who are refractory even to anticoagulation with this. So a change in the valve status will also lead us to a more aggressive timeline for follow-up.
Excelente, doctor. Le preguntamos al doctor acerca de cómo ellos hacen el seguimiento de los pacientes imagenológicamente después del implante de la válvula. Y esencialmente hacen probablemente lo que estamos haciendo todos, afortunadamente, el eco, por supuesto, inmediato post procedimiento, pero al mes y nuevamente un control ecográfico al año en todo paciente que esencialmente tenía preservada la función ventricular. Pero si el stage al principio era un tanto diferente, con función ventricular comprometida, el control ecocardiográfico se hace a los 6 meses. Y si hay aumento de gradiente en el periodo de vigilancia, entonces indican inmediatamente la realización de un CT, y de acuerdo con eso detectan si hay o no HALT, si hay engrosamiento de las valvas, y indican anticoagulación, y luego de eso hacen eco cada 3 meses. Hay algunas HALT que son muy refractarios a anticoagulación, y por eso es tan importante seguirlos muy cerradamente, muy cerca en el periodo de seguimiento imagenológico. Lempiro, ¿tú quieres hacer alguna pregunta? ¿Tienes preguntas de la audiencia? Lempiro, do you have any question from the audience?
Yes, there are some questions from the attendees. One is regarding the youngest age for TAVR replacement in the current and actual clinical practice in the US. ¿Cuál es la edad más temprana para reemplazo por TAVI en la vida real y actualmente en los Estados Unidos?
Muy temprano.
So we are certainly seeing more younger patients who are interested in TAVI as a treatment option. Now, many of those who are maybe in their 50s, let's say, have a bicuspid valve, and we factor that into our decision making, right? If that's a more complicated anatomy for TAVR per se, which bicuspids sometimes can be, is this the right intervention? I will say we have done TAVR in patients in their 50s. I'm not and I think selectively in their 40s, but they usually have a compelling reason. So here are the groups that we will see this in. And I think is the right thing probably. So one is radiation, heart disease. So these are people with mantle radiation for Hodgkin's disease. We know they can have heart surgery, but reoperation is very challenging for them. Many of them don't want a mechanical valve. We think of them as being able to get, say, one heart surgery in their lifetime. So we have a conversation about what is the best lifetime approach, and we'll have them, they have this in their 50s because of radiation. We may elect to do TAVR as the first procedure with the plan that when that degenerates, they can then get surgical AVR with a biologic prosthesis. And then when and if that fails, valve-in-valve TAVR. So we've bridged a lot of time by giving them only one surgery. We have some younger patients who have liver disease, kidney disease. They need transplants. They're inherently high risk. With surgery, in order to facilitate them getting the necessary transplants, we will treat them. So I think selectively we take those groups. But I think what you're referring to is just the otherwise healthy young person. We are seeing people very insistent, and I would say we've had more than a number that are in their 50s, early to mid 50s, that have heard everything, and they basically are refusing to have an open heart surgery no matter what we recommend. And if their anatomy is suitable for TAVR, we'll treat them, but we'll tell them that their next procedure may be a surgery, and they seem to be comfortable with that. I think we try to approach it thoughtfully with the patients, but especially in the United States, people have a lot of their definitive ideas
Even
about what they
definitive
want.
decision, absolutely,
Yeah.
absolutely. Lempiro, tú.
Él dice que cada vez se está tratando de hacer más temprano y lo que él ha visto es que está en la década de los 50 años. Algunos pudieran tener alguna indicación específica a los 40 y tantos años, principalmente en los que tienen aortas bicúspides o los que han tenido lesión cardíaca por radiación. También tiene consideración especial para hacer un TAVR más temprano a los pacientes que van a trasplante hepático o a trasplante de riñón.
Renal.
Yeah.
Y eventualmente, claro, en los Estados Unidos también sucede que el paciente tiene mucha participación en la decisión final, y hay pacientes que deciden a los 50 años que de ninguna manera se van a someter a una intervención quirúrgica. Y entonces, bueno, se conviene en un TAVR y probablemente en que la segunda intervención sea una cirugía, y se llega al acuerdo básicamente por la intervención del paciente en la toma de decisión. No sé si Ángel querías comentar algo.
También comentaba que había, disculpa Carlos, para terminar el comentario que hizo Jonathan, es que el paciente muchas veces a una edad temprana se le decía el TAVR y estaba cómodo con la decisión de él participar en la toma de decisión y decir, me ponen un TAVR, pero ellos hacían mucho énfasis para advertirle que el siguiente
Este
procedimiento iba a ser
procedimiento iba a ser una
una
cirugía.
cirugía cardíaca, o sea que si no la
Sí, pero
estaban
no, no
llevando ahora,
importa,
la
está
iban a
bien.
tener en algún
La
tiempo en el
estaba
futuro.
delatando simplemente. Total.
Sí, con una connotación que tuviese una anatomía
Anatomía
favorable.
favorable, no,
Favorable.
por supuesto,
Ahora está
por
bien.
supuesto,
O sea,
por
es que eso
supuesto.
también es súper importante.
Es muy importante, absoluto. Pero
En
claro,
la
tenía
bicu-
50 años, poco probable que... Pero las bicúspides, bueno, sí, sí pueden tener
Col-
anatomía, dilatación de
Exactamente.
aorta y de acuerdo al tipo de válvula bicúspide, siempre varía particularmente la anatomía de la aorta.
Pero
Ángel,
yo quiero comentar algo que dijo Jonathan, que es el hecho de que hay pacientes que solo tienen una oportunidad quirúrgica en su lifespan y que quizás la primera estrategia de hacer un TAVR, si la anatomía es conveniente, es razonable. Al principio, los TAVR explants estaban reportando una mortalidad a
calidad
30 días muy alta,
muy
pero la
alta.
data del STS que se reportó el mes pasado da una mortalidad de 3 a 4%, que es intermediate, no es severe. Así que
Total, total,
en
total.
un lifetime management, en una estrategia de manejo para el resto de la vida, TAVR primero se hace cada vez más razonable. I'm just commenting how we were taught that a TAVR implant implies a very high mortality in the early experience, but with the most recent experience, explantation seems to carry a lesser mortality, and it's a very reasonable approach to do TAVR first in patients, as you mentioned, that only have one chance for surgery in their lifespan. So.
Yeah, in fact, there are some surgical team specialized just in explant now in the US, and there is a lot of referral for that kind of experts in explant of previous towers. And that is, I think that is one of the reasons the mortality decreased during the last years.
Doctor,
Um,
I think we have the big boss here. Creo
yes. Wow.
que el doctor Igor
Excellent.
ya está conectado y bueno, siempre lo
Okay.
está, que ya está con el micrófono abierto. No sé si le quiere hacer alguna pregunta.
Doctor Igor,
Buenas
bienvenido.
noches, buenas noches.
No, bueno, doctor, usted es uno de los más grandes expertos en válvulas del mundo. Y bueno, el creador de este magnífico grupo de super expertos que usted formó. No sé qué pregunta tendría usted, pero nos interesaría mucho su visión de este procedimiento, del TAVR como opción para la resolución de la estenosis aórtica severa, y cómo trataría usted a sus pacientes de acuerdo con la información que usted tiene disponible ahora. O sea, cuál es su visión personal, no lo de los guidelines, sino su visión personal de cómo deberíamos proceder con estos pacientes.
Sí, bueno, yo creo que es importante recordar que todos los estudios partners y todos los estudios hechos con la Evolut fueron estudios randomizados, o sea que habían, o fueron randomizados a medical therapy o fueron randomizados a cirugía. O sea que había un grupo control, ya fuera quirúrgico o médico, comparado con el TAVR. O sea que hubo muchos de esos estudios que si los pones juntos tendrías una muestra bastante grande de pacientes en diferentes edades y en diferentes características que probablemente ayuden a responder algunas de las preguntas que Jonathan contestó muy elegantemente a ustedes. Pero indudablemente que viendo esos estudios, hubo estudios que fueron simplemente comparando SAVR con TAVR. En pacientes más ancianos, en pacientes más jóvenes, en pacientes que eran excelentes surgical candidates, en todos ellos, inclusive los de bajo riesgo, el TAVR siempre fue superior al SAVR. Algo también en considerar es de que hay una cirugía que estuvo de moda, que prácticamente desapareció, pero que ahora está otra vez en el tapiz, que es la operación de Ross, donde se toma la válvula pulmonar, y se trasplanta a la posición aórtica y se pone un homógrafo en el lado derecho. Y esa sería una alternativa para esos pacientes más jóvenes de que estaban refiriéndose finalmente. Pero ha tenido más entusiasmo los cirujanos en hacer esas operaciones ahora de Ross. Um, No sé si los cirujanos allá en Venezuela están haciendo procedimientos de Ross también.
No muy frecuente, doctor. Honestamente, no es frecuente que nosotros practiquemos ROS. Pero bueno, Bartolomé tiene data más fresca.
No es muy
Okay.
frecuente, pero ya comenzaron. De hecho, están haciendo cada vez que tienen eventos en el Congreso de la Sociedad Venezolana de Cardiología, talleres. Han hecho un par de talleres aparte en centros privados de Caracas, pero también en el tema, en la sociedad le han dado mucha cabida o estimulando mucho tener el ROS como una posibilidad para los
Opción para
pacientes.
pacientes jóvenes. Ujú.
Y ya han hecho tratamiento, inclusive se entrenaron en Osaka, o sea, hay una movida y entre esos uno de los principales es Chadi y dejo de nombrar a muchos otros que han estado haciendo un trabajo igual de insistente y excelente como como el de Chadi, pero sí lo hay, sí hay la movida, aunque no hay el volumen, hay la movida en Venezuela, como lo hemos hablado, nosotros con el TAV y ellos con la cirugía preservadora de la válvula aórtica lo están haciendo muy bien.
Ok, por lo demás me pareció excelente toda la reunión de hoy.
Muchísimas gracias, doctor. Muchísimas gracias. Gracias por estar con nosotros y gracias por haber generado todo este movimiento de la cardiología estructural en Venezuela a lo largo de los años y ahora mantenerlo a través de este gran foro de educación que usted mismo creó. Eso lo agradecemos infinitamente.
Bueno, gracias por todo, ¿eh?
Dr. Jonathan, in your excellent trial, we noticed that the women or the female sex obtain clear benefit of this early report of the trial. How do you change or how can you increase the umbrella of protection or early detection for the female sex in order to give them the benefit of the early intervention? Are you planning something in your cardiac lab, or it just doesn't change anything respect your regular conduct?
Again, I think that we have to go back first. First thing is to go back to the studies that randomized Saber and Taber and look at, how the population for females and males were in those studies and do some comparisons there just to start. And that will be the source to see if you need to do a larger study to see any different. But you may have the answer just from looking at the low risk patients from the Sapien and the core valve. You may have enough data there already.
Yeah, this was definitely the driver of benefit in the trial was accelerating intervention for women. A lot of this was also driven by the subgroup who have low gradient aortic stenosis, which is more common in women.
In women.
I think what this trial demonstrated and is adding to a growing body of evidence is that notifications within the record that prompt treatments and referrals will probably help to capture more patients. And we're seeing this a bit more within our healthcare system because we're integrated onto this one particular Epic healthcare record. And so we are now getting notifications for a variety of things. I'm going to speculate, if you don't mind. The very in thing right now to talk about is artificial intelligence and the implications for this in software. I suspect there's a lot of unknowns about how this is going to be applied in medicine. People think it's going to be everything from reading imaging studies to doing, a variety of things. I think it's probably going to be different than that. A lot of these models are very good at pouring through large volumes of clinical data to kind of pull out certain things and provide notifications. And so I think one of the ways we're going to see the next generation of these types of electronic notifications are going to be leveraging artificial intelligence software technologies so that when a patient has a diagnostic echocardiogram that identifies these parameters that they may benefit from that, those will provide rapid software notifications and easy referral pathways. Yeah. So I think this is one way in which this will be leveraged. And as these things get better, they'll be more affordable, and there's no lack, at least in the United States, no lack of companies that are making their own products that you can use this. So I do think this is going to be one of the areas. Again, this is a target of the societies to improve this. So I think this is probably something you'll see healthcare systems in the United States invest in as these things become available. So I suspect that's going to be one of the ways, but this is all speculative. It hasn't been done yet.
Excelente. Ángel, ¿quieres comentar este último comentario del doctor? Porque creo que es muy importante, particularmente lo del sexo femenino y el uso de la inteligencia artificial, que ya es prácticamente un acelerador o va a ser un acelerador del diagnóstico precoz.
Sí, yo creo que se está moviendo en esa dirección definitivamente de identificación temprana, y todo va junto con el concepto de que tenemos ahora una ventana para tratar a los pacientes, y esas notificaciones ayudan. Antes decíamos que la causa más común de muerte en un paciente con estenosis aórtica severa asintomática era el reemplazo valvular. Y todos los estudios demuestran que ya no podemos decir eso. La mortalidad asociada con el reemplazo valvular en buenas manos quirúrgicas y en TAVR es más baja que observar la enfermedad, o igual en el peor de los casos. Es decir, que la detección temprana permite identificar una condición. Veámoslo en los términos del cáncer. Si tú tienes un cáncer que tiene una sobrevida de 5 años, ¿prefieres una identificación temprana o vas a esperar a que tengas una enfermedad avanzada para tratarlo? O sea, para mí, la identificación temprana va a ayudar a aproximarse a esos pacientes más tempranamente, y va a ser mejor para ellos.
Excelente. Sí, yo creo que le habíamos preguntado al doctor qué pensaba del beneficio mayor que obtuvieron las mujeres en el trial que él presentó de notificación temprana, y dice que fue el principal vector conductor de los beneficios. Se obtuvo justamente en el grupo femenino, y bueno, es un buen mensaje, porque Josefina siempre está preocupada de cómo aumentamos la protección de la incidencia de la enfermedad cardiovascular en mujeres, y efectivamente va a ser una de las vías. Pues cómo hacemos la detección temprana. El grupo más frecuente incluso fueron las pacientes con bajo gradiente, que es mucho más frecuente, por supuesto, en mujeres, y que el beneficio de esto temprano, tú que eres ecocardiografista, vas a tener que combinar inteligencia artificial en tu laboratorio con notificación temprana, con una cantidad de sistemas que rápidamente alerten de que hay una estenosis aórtica en progreso, y hacer una intervención temprana.
Mira, y brevemente, a favor de la inteligencia artificial, me hago un comentario. Los subtítulos de hoy fueron realizados en 4 minutos y medio por inteligencia artificial.
¿Los qué? ¿Los qué?
Los subtítulos de hoy de la charla. Creo
Espectacular,
que
tuvieron los subtítulos.
2 palabras y el apellido de Jonathan, todo estuvo correcto con lenguaje médico apropiado.
Y yo te iba a preguntar, porque cuando estábamos juntos tú lo estabas subtitulando, pero de repente vi una sola palabra que dije, oye, pero esto pareciera que lo hizo, que fue foliolos. Y dijo, ¿será que esto usó algún sistema foliolo? En vez de valve, dijo que era como foliolo. No sé qué fue la palabra que utilizó. Fue lo único, pero fue una traducción increíblemente perfecta.
Y es algo que la doctora Susana siempre insiste y me contentó mucho.
Claro, claro, es muy fácil.
Jonathan, I was just saying regarding the benefits of AI that our president, Dr. Susana Blanco, is always talking about technology, and your captions were actually made in probably 4.5 minutes with AI. So it's a fantastic benefit.
Absolutely. Amazing, absolutely.
Si me permiten, le quiero hacer una pregunta clínica a Jonathan, que es
Por
sobre,
supuesto.
después de un episodio de hold, ¿por cuánto tiempo mantiene el paciente en anticoagulación? Porque nosotros hemos tenido un par de casos donde la paramos y el hold repitió, y después nos vimos obligados a mantenernos en anticoagulación. Vamos a ver que él tiene más experiencia que nos dice. Jonathan, we talk about the phenomenon of valve thrombosis and hold. And, in my clinical practice, I had several cases of it. And I have few that we stop anticoagulation. I mean, we treated, let's say the gradient at follow was 30. We initiated anticoagulation. We did a 4D CT scan. It proved that it was hold. It improved. gradient came down, let's say, to 15. And then let's say I have a case where we choose warfarin as an anticoagulant, and the patient didn't want to take warfarin. So we went to a DOAC. And then 6 months later, the gradients are high again. So it appears to be something intrinsic to the patient, maybe the anatomy of the valve, whether it wasn't expanded properly, whether it's the lack of flush in the neo-sinus, whether it's a hypercoagulable state of the patient, but none of those variables appear to be reversible. So what are you doing in your practice? Because HALT comes and goes, and sometimes it's subclinical. But once HALT is clinical and responded to anticoagulation, for how long do you treat it?
Yeah, Angel, this is a great question. So I think in the beginning, we initially thought of this as an early phenomenon that would be less likely to recur once there was full endothelialization of the valve. So we were more concerned about the early phenomenon of HALT. So we would treat it for 3 or 6 months, and if it resolved, we would stop anticoagulation. Now, what's happened clinically in my practice and what we've seen, I think has changed my thinking about this, which is we've seen more cases of late halt, which goes against the concept that this has to do with endothelialization. And I've seen more recurrent halt after cessation of anticoagulation. So I agree with the point that you are making that probably a lot of halt is going to be due to non-modifiable factors, right? That they are going to be there. So now in my practice, I continue anticoagulation indefinitely. You know, and if they develop some potential relative contraindication and it's been a long time, then we do a risk benefit and maybe decide to stop it and observe more closely. But I think our thinking on this has evolved from a transient phenomenon to non-modifiable risk factors. So I treat HALT indefinitely.
Thank you. Thank you, Jonathan.
Importantísimo, ¿no?
Sí, voy a traducir para el grupo. Esencialmente, el concepto del HALT, por mucho tiempo, muchos intervencionistas y cardiólogos clínicos lo tomamos como un fenómeno transitorio que era temprano después del implante valvular y que probablemente se debía a la falta de endotelización de la válvula, pero que la experiencia clínica ahora demuestra que hay pacientes que tienen episodios recurrentes y tardíos en los que ya no se puede acusar a la falta de endotelización como el disparador y que hay una tendencia a mantener estos pacientes en anticoagulación crónica. Por supuesto no tenemos estudios, pero estaba compartiendo la experiencia del doctor Passeri que es bastante importante.
Un tratamiento indefinido con anticoagulantes y lo paran solo si hace complicación del anticoagulante. O sea, bien interesante. Lempira, ¿tú tienes alguna? Ah, no, Carlito, tú tienes una pregunta.
Sí, no, which is your drug of choice for treating HALT?
So I actually start with a DOAC just because it's easier for patients, and if it works, great. If it doesn't, then I switch to warfarin. And part of that is twofold, because if they fail the DOAC, one is warfarin is going to target more pathways in the clotting cascade, so it potentially is more effective. And you have the ability to adjust your INR goal if they are not responding to it. But I always start with the simplest. And I will do a DOAC plus 81 milligrams of aspirin in combination.
Okay. Excellent, doctor. Lempira, do you have any last question? Lempira?
No more questions.
No, for the audience. Okay. ¿Qué dices tú, Bartolomé?
No, bueno,
Qué conversación tan buena, ¿no? Qué
sí, vale.
conversación tan
Pensamos
buena.
que era cortica y duró más la discusión que la charla. We're saying that
No, aquí podemos seguir, pero tenemos que respetar al doctor.
This is one of the
tiempo
few
del doctor.
times. Claro, this is one of the few times where the discussion has lasted longer than the talk. We're very happy. No, quería insistir de que, bueno, fíjense que este tema del HALT y este tema del seguimiento de los TAVI es fundamental porque la sociedad estaba haciendo un trabajo en el capítulo de imágenes muy duro en mantener actualizado en este tema estructural y los pacientes de TAVI están viniendo de todo el país y los reemplazos valvulares también. Muchos van a Caracas y se intervienen y vienen de otros lugares del país. Entonces, el seguimiento de eco muchas veces en el domicilio y si no hay las herramientas para mantenerse actualizado en cualquier lugar donde vive el paciente, que es donde probablemente se termina haciendo los ecos de seguimiento, bueno, se nos puede pasar un hold por alto y un paciente que fue una intervención tan compleja y tan costosa como un reemplazo por la vía que sea, termina con un resultado subóptimo por un tema de terapia médica, ¿no? We're saying, John, that in Venezuela it's very important that the Venezuelan Society of Cardiology has increased the quality and the amount of events regarding imaging. Because sometimes you do a TAVR in Caracas, and maybe the patient lives very far from Caracas, so the follow-up is going to be with a local doctor, and the importance of on knowing about the proper disease following, as you said, the intervention regarding surgical or transcatheter. So it's very important for us. Pero de mi parte, gracias a todos.
Doctor, we are very, very, very grateful with your expertise, with your time, and with this wonderful conversation that we would like to prolong, but we want to respect your time, your family time. For that reason, we are going to close. But we are very interested in prolong this conversation for a long period of time. I would like to invite you for a new presentation because you are very, very smart in your presentations. Ángel, ¿tú te quieres despedir de tu profesor?
Yes, Jonathan, thank you, my friend. It's always a pleasure. There is not a time that I haven't seen you that I walk out more knowledgeable than before I saw you. So thank you for that. And I appreciate for all you do. And I hope to see you in CRT, TCT, or New York Valves, one of those.
Yes, well, thank you all so much for
Yes.
the kind invitation again. It was really my pleasure, and I really enjoyed the wonderful conversation. Be happy to come back again if you were to invite me. Thank you so much.
You are very generous, doctor. Thanks so much for your time. Thanks so much.
Los dejamos con la próxima actividad el mes que viene a los 47 asistentes y 8 panelistas. El doctor Cudemus nos va a estar hablando bajo recomendación de Pablo Rengifo, quien es el presidente actual de la Sociedad Igor Palacio, sobre el tema de ECMO, una tecnología que tenemos disponible en Venezuela y él nos va a hablar un poco, el doctor Cudemus, el 26 de marzo sobre vamos a decir, el espacio y los beneficios del ECMO en las patologías cardiovasculares. Bueno, muchas gracias a todos. Carlos, doctor.
Carlito, Josefina o Empira, si quieren decir algo.
Bueno, sí, voy a aprovechar para recordarles en nuestro plan de educación continua, el sábado tenemos nuestra reunión bimestral, la primera de este año, de imágenes cardíacas, es en el Hospital del Llanito de 9 a 12 del mediodía, donde habrá casos muy interesantes de todos los posgrados. Y bueno, tienen a la crema innata de las imágenes ese día y todas juntas para discutir los casos, no desaprovechen esa oportunidad. Y el lunes 9 tenemos un webinar de la sociedad sobre enfermedad cardiovascular en la mujer según las diferentes etapas de su ciclo, vamos a decir, hormonal, para que entonces eso es en virtud de que el 8 es el Día Internacional de la Mujer. Entonces los esperamos.
Felicitaciones en anticipación.
Gracias, se aceptan.
Buenas noches, gracias.
Buenas noches y
Gracias
hasta
a
pronto.
todos.
Ángel, muchas gracias. Saludos en Texas. Que te comas una buena arepa esta noche.
Amén, gracias.